Welcome to another episode of the Your Longevity Blueprint podcast. Today, my guest is Dr. Jill Valerius, who's a dual board certified physician in family and integrative medicine with an additional certification in functional medicine. She's been practicing family medicine for over 20 years and over time has realized that focusing on diet, lifestyle, and nutrition are the only ways to treat and avoid chronic diseases effectively. Through listening, educating, and empowering patients, she's been able to help patients reverse and avoid chronic medical problems and unnecessary prescription medications. Her mission is to educate and empower people to avoid and reverse health problems, allowing them to live happy, healthy, and full lives. I love that. Welcome to the show, Dr. Valerius.
Thank you so much. I'm so happy to be here. And yeah, I think today to explore with you, it sounds like a drug that we're both using
Yes.
in practice. And
And
yeah, like
something,
just to let people know what we're using and what we're doing.
sure, something we haven't talked about the podcast on barely at all. So I'm excited just for this new topic for the listeners, which is low dose naltrexone. So we will get to LDN. However, you're from Alaska, which is very intriguing to me. So first, kind of tell me, before we get to LDN, like tell us your story. How did you land in Alaska? I don't even know. Are you from there? Have you always practiced there? Kind of tell us about yourself, and then we'll get into our both of our uses of low dose naltrexone.
Perfect. So I grew up uh, Minnesota and Wisconsin. And I went to undergrad in Wisconsin, and I'm a PE major. I was one of the only PE majors in my medical school class, but I was an athletic trainer for a few years before I went to med school. So I went to medical school in northern Minnesota and in Duluth, and then you graduate in the Twin Cities, Minneapolis, St. Paul, Minnesota, and then I went back up to residency in Duluth. And after that, I worked for about a year and a half doing urgent care and ER, and decided if I wanted to go back into family medicine, I needed to start doing that again before I'd get pushed, just not feel comfortable doing it really.
Sure, sure.
And I had the opportunity to come to Alaska. And so I came up here and checked things out and was like, okay, I think I can do this, and committed to 3 years. And I am at 21.
So you never left. I mean, to live, probably to travel, but not to,
I,
yeah.
yeah, I never left. So I helped start a family medicine practice here, which has grown and still exists now, but 10 and a half years ago left that practice. As I'd started, I'm a family practice doc for a number of years. I delivered babies, I did all
Hmm.
of the things. And then I stopped delivering babies and was focusing on outpatient care, as well as some in-hospital stuff. And as the hospital grew and changed, and practice was just changing, and you got to see people faster and you got to do all the things. I started to just lose my mojo for it all, and I I'd learned about functional and integrative medicine as like a med student and a resident. Like I had a couple people just
Yeah.
a couple years ahead of me,
Yeah.
and
Early
so
on, that's great for you. That, yeah, yeah.
very, and so I was really intrigued, and I've always been interested, and I kept my hands like reading that kind of stuff. And when I was really kind of at that point of like, what do I want to do with my career? Do I want to continue to do this? Do I want to build bicycle wheels? Like what do I want to do? And I started my road through the Institute for Functional Medicine. And so over 2 years' time, this was, boy, 10, more than 10, 13 years ago, I suppose, 13 or 14, I went through all the IFM courses. I got boarded in integrative medicine. And kind of at the culmination of that is when I was like, I can't stay in this practice that I'm in. Um, and mostly I was isolated in that practice in the sense that I was kind of an island in a group, uh, just because I was trying to think about things differently.
Mhm.
And I ended up opening up my own practice, which has just been an absolute blessing. It's 3/4 of a mile down the road from my house, so I can walk to work. It's right in the middle of downtown Palmer, which is a town of about 6,600 people. We're just an hour or so north of Anchorage.
Sure.
And yeah, and that practice now has evolved. I'm 5 years into a membership-based practice now, so a smaller number of patients in my practice,
Sure.
which allows for, as anybody listening can imagine, way better access to your physician. I have a nurse practitioner that works with me as well. And
Yeah.
so you way better access, and I can just provide the level of care
That
that I
you
would need for
want.
this.
Yes. Yes.
Yeah, so I mean we spend time with our patients. Your first visit's an hour and 15 or an hour 30. Like
Mhm.
we spend time with people, and I love that because that's how I can help somebody make changes. And we can all get education, we can learn things, we can know the right things to do. The challenge is, how do I do that? How do I do that in my day to day? How do I start to incorporate different foods? How do I add different lifestyle things? So that's kind of how I got where I am. And it's really directed my practice in that regard too, and what I learn. And LDN or low dose naltrexone is another one of those things that
Another tool in our toolkit, right? I mean, practicing integrated medicine for the listeners, integrated medicine integrates or combines, conventional medicine with complementary and alternative methods, right? For which there is evidence of safety and effectiveness. So low-dose
absolutely.
naltrexone is one of those tools. It's a drug that we do use, but we use it a little differently. So maybe let's get into that. I want to know how you've used this tool in your toolkit. So let's just maybe talk about what it is. So what the heck is LDN or low-dose naltrexone for the listeners?
So low dose naltrexone, I think the way to start that is what's
Naltrexone,
naltrexone?
yeah. Yes,
Yeah,
thank you.
so
Yes.
naltrexone is a drug that was discovered quite some time ago, and it is an opioid antagonist. So everybody's like, what does that
What is
mean?
that? Yeah.
So what that does is that the drug binds our opiate receptors. And so then we're going to have to talk about like, where are opiate receptors? But it binds them, and it was initially used with opioids, so morphine, streetwise be heroin, those different sorts of drugs, when we realized they cause respiratory depression and could actually kill a person,
Mhm.
we were they were looking, I guess as medicine, we were looking for how do we reverse that? How is there something? And naltrexone is basically a product of that. Naloxone was the first one, and many
Yep.
people will know what that is
Yep.
because it's in schools, it's in cop cars, it's
Yep.
naloxone is all over for drug abuse. Naltrexone is the oral version of that. And so it blocks these opiate receptors. So in in a heroin or a morphine overdose, it can be life-saving for sure. So as we learn about these things, naltrexone probably more commonly now is used in or not opioid, I'm sorry, alcohol dependence. And there's something called the Sinclair method. And it will actually help people when they take oral naltrexone. People will just drink less over time. And so we knew how this is working. And it was I want to say it was in the 80s. There was a Dr. Bahari in New York.
Yep. 1985. I was just looking that up this morning in the LDN book. Yep. Yep. You're right. Good memory.
Yeah, and so Dr. Bahari was treating HIV and AIDS patients, and he realized that a lot of them had low endorphins. So that's kind of your runner's high. That's also part of what gets people hooked on opiate drugs is these
Sure.
endorphins. And so he noticed they had low endorphins, and so he started using this lower dose naltrexone, but he also realized in these folks that they weren't getting the infections. So he had a one group of folks who were doing normal HIV care, and another group that was on this low dose naltrexone, and those folks didn't progress. And so so
Yeah.
through that we
Interesting. Yeah.
figured out there's immune effect, and so when we use low dose naltrexone, I mean, I think it's important for people to know like it's not it's not FDA approved for low dose. low dose is anywhere from like 0.5 to 4.5, maybe 6, 9. You're going to find different things
Hmm.
talking to different practitioners versus
Milligrams, just for the listeners. Yep, yep,
milligrams,
yep, yep.
versus 50 to 300 milligrams. And so, because studies have been done between 50 and 300 milligrams, like we know the safety profile of this.
At high doses, yeah, exactly.
Absolutely at high doses. But then that also helps us because I think in the last handful of years, we've had a lot of drugs coming in out of the media, like that's not FDA approved. And the reality is there's so many medications that we utilize in uh, medicine, not just primary care, but psychiatry, endocrinology. There's so many medications that we use off label.
Right.
And I think that's important for people to know just because it's important to know it's off label. And off label just means like now, naltrexone was studied for opioid and alcohol dependence in a specific group for a specific indication, and it gets approval. When we use it in any other way, it's off label. Like I would say an example is like think about a lot of psychiatric medications we'll use, like commonly will be like uh, Zoloft or Paxil. Those are basically tested in adults, but they're used in children.
Hmm.
Whether you or I are using them in
Right, right,
children, but
right.
they're used in children, and that's really an off-label use.
Yeah,
And
yeah, good
so
example. Yep.
yeah, and I think it's just important for people to know that because I feel like there's some connotation sometimes, but it's also important for us as providers to understand that it is off-label and that it's about having that conversation, which, lucky for me, I have the time to have that conversation about, can we use this? Yes, we can, or no, we can't, or we get to make decisions. That's practicing medicine.
Yep, yep.
And so, low dose naltrexone, through Dr. Bahari's work, we learned that there's impact on immune activity.
Hmm.
And so, when we think about low dose naltrexone, so that's using that smaller milligram dose, zero point 0.5 to, we'll say 6 right now
Sure,
for
sure.
practical state, you know, different effects there than there are at 50 to 300 milligrams. And when we look at those effects, we have to think a little bit about like, where are opiate receptors? We think about them commonly in our brain. And when if I'm utilizing those or I have a patient utilizing those, uh, they don't change the pain, they change our perception. And so what it does is it maybe we can say disrupts that nerve transmission. Like it will happen with different neurotransmitters in our brain. It does that with nerve transmission in our extremities or in our peripheral nervous system. And so that's where I think that's very interesting. So we know how it works from a pain standpoint, but we also have opiate receptors on many of our blood cells. So on white blood cells, I think a lot of people listening to your podcast will probably know or have heard of like a mast cell. So when we
Hmm.
think of different mast cell issues, so it's really neat in that it helps us modulate that through both opiate receptors and through other receptors called toll-like receptors.
Hmm.
When I think when we think about how does this work, like when you think about a drug um, like naltrexone at a full dose, it locks into a receptor and it blocks the activity of that receptor. And when we use it at a tiny dose, so a very fractionated dose, it blocks the receptor for a little period of time, like 4 to 6 hours. Then what happens is now that that drug is basically being broken down. So these receptors, when there's a tiny blockade for hours, they upregulate, they get more sensitive. We produce more endorphins that our body produces.
So it almost tricks our body into making more. So I want to,
It,
this is an excellent explanation, but I want to go back really quick just for the listeners too, when you're saying the higher dose naltrexone literally blocks the opioid receptor. Therefore, it makes the opioids, so AKA pain meds, not work, right? And alcohol not give you that buzz, like not work, right? That's why at high doses it's used to get patients off drugs or alcohol, whatnot. So we're using it off label in very low doses, like you're saying, that's gonna block the receptor a little bit, but kind of due to that, we'll almost say that deficiency or that deficit, it due to this feedback mechanism, right, tells your body to make more in essence. So it kind of tricks your body into saying, actually, we don't have enough of this. Hey, let's make much more to compensate. So it kind of tricks our body. I don't know if I explained that well, but to the listeners, essentially it's making us make more endorphins, which are good.
right,
Yeah.
right. When you think
Yeah.
about, in those first people that, this has been, I think you and I both followed this, like the evolution of how this has been used in the different applications it's being used. And so when we get, think about if people with pain, um, if we can block that receptor for a little bit, but we can get your body to make more endorphins. So it's kind of like your body's own version of morphine.
Yeah, or
That's
like you
our
said, the
runner's
runner's
high.
high. Like when you said the
Yeah.
runner's high earlier, that's a great way to, yeah. Yep.
So if we can get our body to make more of these and be more sensitive to them, I think about people who aren't sleeping well because of pain.
Yeah,
A big group of patients is people with like fibromyalgia and chronic fatigue
sure.
can see really, really big benefits with some of these things. And so, yeah, like the application is amazing. And to be able to go, you know, jump from how did we get from this big drug to this like little drug and figure this stuff out is neat. And when, I think a lot of times we think about trials as being great big, thousands of people. We think of phase one, phase two, phase three trials of drugs, and which lead to FDA approval. The likelihood that low dose naltrexone would ever end up in that process, I think, is very,
Yeah.
very low.
Yep. Agreed.
It it's an inexpensive drug, and it costs money to do those great big things. So over time, there have been more and more and more little trials showing efficacy of utilizing a medication like low dose naltrexone in like such a wide variety of conditions.
Let's get to those next, but I want to go back to how this works. You explained it really well. But essentially, again, back in this book, which this is a great resource for patients, there's several iterations of this, just called the LDN book. You can get this on Amazon, literally, if you find this interesting listening to a discussion today. But in the book, the author talks about this endorphin deficiency that a lot of patients have and how LDN can target that endorphin deficiency, balance the immune system, essentially reduce inflammation, modulate pain. And the author mentions that this drug, which we were kind of talking about before we started recording today, is touted as one of the safest immune modifying treatment options available. So for a lot of autoimmune diseases, it has great use. So that's kind of how it works. So let's talk about subsets of patients that you've used this in, and we should talk about kind of dosing. You already alluded to the fact that we use low dose, and that it's pretty affordable. Many times we have to compound it to get it at this low dose, though, just to tell the listeners, because they may be thinking, where am
Yes.
I going to get this? What's commercially available is the 50, 100, right, milligram doses. We're using much lower doses that have to get compounded, just to be clear. But to go into applications, kind of give me some examples of uses with your patients, kind of, I guess, commonly how you've been using this in practice.
Right. So, I have to credit me using this medication and learning about it, how, nearly, I don't know, 10 years ago, uh, is the credit of a patient who came to me that had arthritis and was working with a rheumatologist and was not tolerating the disease modifying drugs that are commonly utilized, and came to me and just said, hey, I've looked at this. I kind of want to try it. Would you be willing to prescribe this for me? And so we looked at it together. had a conversation. I'm
Yeah.
like, let me look at it a little bit. And, when I looked at it, I was like, wow, um, the kind of the top adverse effects are like vivid dreams and nightmares can happen in the first week or two you're on it.
Hmm.
And sometimes some GI upset, so diarrhea, constipation, those kind of things. And the upside of this is it going to help my patient with the
Severe
pain?
pain. Yeah. Yeah.
Yeah. And so I was like, yeah, we can try it. And I'm will ever be grateful to the patient for pushing me down this road. I read the LDN book like we talked about. I went to an LDN conference years ago and then was able to listen to people who had been using it, even at the time that I went, like for 20 years. And I find it so interesting, which I suspect you've seen too, when we're in this integrative medicine world of integrating multiple different, known treatments. You learn about something new, and then you show up at a conference and there's somebody who's been doing that. They're like, I've been doing that for 20 years. You're like, what? So it that got me down the road, and this patient had benefit. And then I started utilizing it more as I learned more. I was using it with some of my folks that have had fibromyalgia,
Hmm.
which will just give you pain and fatigue.
Hmm.
Oftentimes there's depression, not always there's depression. And it's unfortunately sometimes a group of patients that gets really under and mistreated, I feel like, if somebody has fibromyalgia.
Sure.
Hopefully less so now, but it has
Yeah.
historically.
Sure.
But
Sure.
seeing how that has helped people improve sleep, uh, improve their pain. And I do see, interestingly, this would be probably more of my autoimmune folks, rheumatoid arthritis, psoriatic arthritis, Crohn's, lots,
Hashimoto's. Yeah. 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 Yeah.
Hashimoto's.
Yeah.
It's interesting, like a lot of those folks, I can just say anecdotally, and I haven't written it up as a study, but how many of those folks don't get sick as often?
Yeah. Someone
It's
should do a study. Yeah.
well,
Yeah. Yeah.
yeah, it would be very interesting. And reading through here, another colleague that uses this is a Dr. Kent Holtorf, and he's been
Yeah.
using this stuff for a long time. And interestingly, like they've actually followed like immune markers
Yeah.
on a
Yeah.
lot of folks. And
Yeah. Yeah.
and and so you could really, I mean, there's an area, and I think that's where this clinical data is coming from,
Sure.
is people writing this up. But so yeah, I've used it in a lot of autoimmune. You can, and I have not probably been as aggressive using it in cancer cases. And
Yep.
I would say 9 or 10 years ago, there was an oncologist at this conference that was definitely using it.
Yep. For every cancer patient. I've heard that too. I don't see a lot of cancer patients, but I've heard the
Mhm.
same thing. So let me go back just to reiterate again for the listener. So you mentioned chronic pain, fibromyalgia, even myofascial pain just in general. And then I
Yep.
do have some patients with CRPS, not a lot, but that's
Yep.
complex regional pain syndrome. And a lot of those patients I feel horrible for because they have tried a million things and yeah, they have pain. So that even for osteoarthritis. And then autoimmune conditions you mentioned, like the first patient with who probably had rheumatoid arthritis, MS. I see a lot of inflammatory bowel, like you said, a lot of Hashimoto's. This isn't always going to lower thyroid antibodies, but a lot of the time it will help.
Yep.
So patients who come in out the gate, I mean, we do want patients to change their diet and to reduce inflammation in general. Um, but for patients who maybe have already done that and their antibodies aren't going down, and we're trying to figure out what else we could do to help them, trying them on low dose naltrexone many times is very helpful. So when that
Right.
happens, when we put them on LDN, yes, they can feel better, but many times the antibodies go down, thyroid function goes up, so we have to lessen the medication, which
Right.
is it can be a bit of a hamster wheel or a goose chase, but it's a good thing. It means that, thyroid function's improving and now we need to lessen the amount of the thyroid medication, which is cool. I like to see that as a provider.
I totally agree. And I would say, like you said, we obviously want to help people change diets and lifestyle, and all of that is so important. But I don't ever discount utilizing a medication like this in a well-informed situation, because sometimes if we can get somebody some pain relief, we can improve their sleep.
They'll be more
we both
motivated
we
for
both
the, yeah,
know through
yeah, yeah.
training, like, yeah, if I'm sleeping well and I don't hurt and all those things, you know what, I can make better food choices.
Mm-hmm.
And you have, and like I would say, even for folks, I would say brain fog. I have had people with irritable bowel, Crohn's, colitis, different GI things that we've utilized this for, notice that their depression has improved,
Sure.
especially if there's some inflammation going on with that. And really there's a couple ways, it's via the opiate receptors on our immune cells, but also the ability for this drug to basically bind to toll-like receptors. Toll-like receptors, when they're generally bound, and I'm just going to say this as totally in general. We're not going to go into the 10
Yeah, yeah,
different
yeah,
ones.
yeah, yeah.
But in general, when that happens, that's pro-inflammatory. So it starts an inflammatory cascade. And and if we can bind that receptor and stop the activity, we're turning off some of that inflammation. And that's how that's helping us in autoimmune. When you think of
Yep.
immune activation, something has triggered it to turn on. Is it something in our diet? Is it a
Right.
virus, bacteria, like
Which we
something in
want
our,
to figure out, but
right,
concurrently we can use this tool. Yeah.
right. So yeah, we can actually help you. And that's why I like to talk to people about, like, I can help you feel better. Doesn't mean we don't stop looking for what the problem is. We will continue to do that, but like having you feel better while we're doing it is
Yes.
potentially a bonus.
Yes.
And sometimes our immune system can just get triggered and get turned on. And now it's like hypersensitive. So now everything kind of triggers it. And in cases like that, that's where, and I think we see that with mast cell activation and people with histamine responses and allergies. Uh, it can help just like settle that down a little bit.
It might,
And when we reduce that noise, if you will,
yes.
now we can kind of try to parse out more details of maybe what's going on.
I think it I think it blocks NF-kappa B too. I'm not sure about that, which is just another inflammatory. Yeah,
Yeah,
yeah, yep.
it does via the toll-like
Like
receptor.
receptor. Okay.
Yep.
Good, good. So speaking of calming inflammation too, it does have use in dermatologic conditions as well.
Mhm.
So I've had patients who come in with just a weird rash that we just cannot figure out. We try low dose naltrexone and I don't say voila, but not that LDN can just fix things forever, but like you said, it can dampen or kind of lessen that immune, we'll just say sensitivity or whatnot, and can
Right.
improve the rash. So psoriasis, lichen planus, lichen sclerosis, I do use this in lichen sclerosis, vitiligo, eczema. I have used it in bullous pemphigus before. I read the book and I had it, what do you know, after I had read the book, I had a patient come in with that condition and thought, okay, here we go. Let's try this.
Right.
The book says it could help. So, rare. I don't have many patients with that, but can help. Or just itching. Itching
Yep.
also back to the mast cell, issues, and obviously in mast cell activation syndrome too. But this just has so many wide uses. So I don't know if you want to comment on any of those. Then I want to get into like women's health uses too. But
Right. No, I would say, I mean, I would agree with you, like all of those different things that are, yeah, really increased immune activity. And yeah, it's quite amazing how this can be helpful for people at, and it's not helpful for everyone. There's not
right,
always like this
yep,
dose related response. Everybody, settles at sometimes at a different dose. I'm not going to say everybody, but some are at 4.5. Probably most of my patients end up at about 4.5, but some at 3,
yep,
some at 6.
yep, mine too. Yep.
So yeah, I think it's really really helpful. And I mean, mostly probably what I'm using it for is like arthritis
Pain and autoimmune diseases. Yeah.
related, yeah, autoimmune
Yep.
conditions.
I personally used it for infertility and endometriosis. So get going on to some women's health uses.
Yep.
PMS, PCOS, and infertility as well. Again, because in all those patients, I'm usually recommending gluten-free, dairy-free diet to lessen inflammation. But guess what? LDN can also lessen the inflammation, right? Make
Right.
the uterine environment more hospitable to a fetus. So it was helpful for me in achieving pregnancy, but it's also been helpful for reducing endometriosis related pains. So
Right.
just another use there. It can be used for PTSD, traumatic brain injury. You already mentioned depression and anxiety. It's even been, I don't see children at my practice. You obviously do in
Yeah.
family practice, but even has been explored in uses for autism as well. So
Yeah.
and chronic infections like Lyme and mold and cancer, like you mentioned. So it's like, who couldn't benefit from this?
Right.
You-
I mean,
yeah,
it's an interesting, it's an interesting medication. And we were speaking before we started recording
yeah,
about
yeah.
a, a doc that we've both been educated by over the years. And she was an ER doc and 44 years in practice and is like, this is like one of the most powerful, interesting meds. And I would say the same, like of different things that have happened in my 25-year career. Like this is it's very interesting. Like it's just, it's a repurposing of an old drug. And I think, I'm grateful that I've learned about it. I think you could practice medicine and not know about this at all. I think a lot of people do.
Yep.
Uh, but I think when we learn some of these things and being open to considering it, like the benefit, like I have seen in a lot of my patients from learning about it and then utilizing it. I've probably had two people in all that just didn't tolerate it well.
Let's go there. Let's go there next. So, one of my next questions for you is, have you seen this be well tolerated? Kind of yay or nay, and kind of go through. You already mentioned a few of them, but mention the adverse reactions as well. So,
Yeah,
we'll start with, do you feel like it's pretty well tolerated?
I do feel like it's pretty well tolerated. I generally, and it's very interesting when you do lots of reading. In the UK, they often use it and dose it in the morning. That's what I read.
Yeah.
I
However,
have,
through all my training, I was told that in the evening after
in
9
the,
p.m. But yeah,
right.
yeah.
So I usually have people take it before bed. That way you get that blockade for 4 to 6 hours while you're sleeping. People tend to sleep well
Yep.
and they wake up because those receptors have upregulated your endogenous or
Production.
endogenous
Yeah, yeah.
endorphins,
Yep.
your happy hormones are cranking up, and so then you're waking up and feeling good. So generally, it's well tolerated. Like I will have people sometimes have the weird dreams,
Yep.
and I'd say of all the adverse effects, that's probably the number one thing I've seen.
Me too. And it's one thing if you have like crazy happy dreams, but if you have crazy lucid nightmares, then that's a little different. Like,
Mhm.
so for my patients who have those, either they push, typically I recommend, well, how bad are they? Like, if you can
Yeah,
push through, because sometimes the side effects are short-lived, or in those situations, you can take it in the morning. I mean, that is
yeah.
definitely an option. But very few of my patients have had horrible nightmares, but it can
I,
happen. And
I
they'll tell
totally
you,
agree.
they tell you when that happens. Yeah.
Absolutely. And I would say so that's probably the number one side effect. Rarely will I have somebody that has a gastrointestinal side effect. I've not had, I don't know, maybe I've had one person say they had headaches,
Yeah.
so, but generally, evening dosing, I usually start somebody like at 1.5 milligrams, and then we'll double it. Really, we'll go to then 4.5.
After a week, or how do you titrate it up?
I'm a little bit slow, so I say a couple weeks. I give the patient, I just say, here's what we're looking for. And some people can take it for months before they notice something and be not sure that they notice something.
Sure.
They stop it and then go, oh, wait, maybe that was doing something for me. So that's the challenge. I mean, that's a challenge. That's a
Yep.
challenge, I'd say, with anything.
Yep.
But most people tolerate it well at night. Like you said, if I have somebody who doesn't tolerate it well at night, I can have them take it during the day. And some people, we all see people, and people will come in and say, I'm super sensitive to anything. Like I just don't
Yeah.
tolerate anything.
Yeah, I have patients who's like, I'm sensitive to air. Okay, we're going to start you a
Yeah.
really low dose.
And then yeah, and I will start somebody maybe on 0.5.
Mhm.
The one area, and if people start to look into this, they'll see there's very low dose and ultra low dose. I'm not really utilizing those in general.
Mhm.
I think, very low dose would be point 0.5 milligrams. So sometimes we'll do that as we're bumping up, but
Yeah, in my
yeah, really,
sensitive patients, we do the same thing. Or I've
yeah,
even done some very few patients, but I have a handful. We've done topical low dose naltrexone too,
yeah,
if they just can't tolerate it orally. But I do think oral is better than topical.
right.
But
And I would agree I guess it's different for where everybody lives, where you're going to get this from. Like for us here in Alaska, I'm often ordering this through a compounding pharmacy. We have one, I think we only have about two in the whole state of Alaska at this point.
wow. Yeah.
And so I often will order through a company in Colorado
Yeah.
that I know that uses gluten and dairy-free products. So
Sure.
which can often be a thing with autoimmune diseases,
Yeah, of course.
many
Yep.
of us know.
So we kind of talked about average doses. So 1.5, then 3, then typically go up to 4.5. If I am not achieving symptom relief, I'll go up to 6 or 9. But again, those are like rare cases that we do that for. And I agree with you. Sometimes it's hard for patients to know. Like it's one thing if they know, oh my gosh, my ANA has reduced or my CRP or like there are antibodies, right?
Right,
Hashimoto's antibodies have reduced. It's another thing when they didn't have any inflammatory markers that were elevated to start with. So sometimes it is hard to gauge, is this improving or not? But
right,
typically that's what patients will do. They will stop it. And then if they feel worse without it, go back on it.
right.
So what are some key safety points? Like, are there any labs you check with these patients? What should they avoid use with, like combining this with?
Sure.
Um, Go there for me. Kind of safety. Yeah.
I, yeah, from a safety standpoint, I mean, I have a family medicine practice, so I check labs on people. It is not common at low doses to have issues with your liver, certainly even kidney function, but I will check those things on baseline and periodically.
Me too.
Uh,
Yep.
I kind of think we need to do that with every medication,
Yeah.
but that probably from that standpoint, in terms of monitoring, that's all I would do. And then the number one thing that I would watch out for is if you are someone who takes an opioid medication. So if you take hydrocodone or boy, Vicodin, or you get morphine or OxyContin or Percocet, like if you take any of those medications for chronic pain, you can't take this. Like I would just there's
Yep.
ways around it potentially with ultra low dose, whatever
And
that, but that
timing and yeah, yeah, yep.
yeah,
Yep.
that's not my practice. I would say if you take that every day, I would not take low dose naltrexone even because you could really honestly, what happens is you're competing for the same receptor site.
You're going to make your pain meds not work. It doesn't make sense. Yeah. Yeah.
Right. And you could go into withdrawal. That would be even worse. And so that's the biggest thing. If you are somebody who is on low dose naltrexone and you need to have surgery, you know what? You can stop the low dose naltrexone 1 to 2 days before you go into
Mhm.
surgery. And then when you're done utilizing those pain meds that you might need, once you're done, then you can resume this. For somebody who had I don't know, a dental procedure done, if you take that pain med that night, you know what I wouldn't do is don't take your
Low-dose
LDN
naltrexone
that
that
night.
day.
It's
Yep.
just,
Yep.
yeah, it will just waste it. But
Yep.
it doesn't mean you can't take a pain med. You're just
Ever.
not
Right.
going to,
Yeah.
yeah,
Yeah.
you're just not going to take them at the same time as
Yep.
as most important.
Yep. So just remember that if you're on this and you do have to have surgery, we just need to time you stopping this prior to needing anesthesia or pain meds or whatnot, right? So that they
Right.
work. Gosh, I was going to ask something else on that. No. Oh, alcohol. What about
Yeah.
alcohol?
Well, if you take LDN and you drink, you might not get I don't know, the
Buzz, the yeah,
buzz from
yeah.
alcohol. So, and really, honestly, that's the basis of this Sinclair method. That would be a little bit different. You're using larger doses of naltrexone again, but it's a very effective treatment for alcohol
Hmm.
abuse and addiction is to utilize naltrexone. But I have a lot of folks that are on low dose naltrexone that often they're just like, I don't know, I just don't drink. I don't know, I don't
Hmm.
drink very much anymore, or
Yeah.
and I think because it will potentially just kill the buzz of the alcohol. So
Yep. Yep.
it
I
won't hurt you, but
You're wasting
yeah,
your money. No,
right. Right.
having
Yeah, it'll actually
having
help you.
yeah, or speaking from experience, so I've taken low-dose naltrexone on and off through the years. So if I and I drink rarely, but if I'm gonna have a glass of wine, dry farm wines, high quality stuff, or have a margarita or something, like you said, I just typically don't take the LDN that weekend or whatnot. So there are ways around it. It's not that if you're prescribed this, you can never have a drink of alcohol. But it,
Right.
yeah, doesn't make sense to be drinking consistently and or taking pain meds consistently if you want to do low-dose naltrexone. So yeah, good points there.
Absolutely. And to add to what you just said, like people wouldn't have to worry about like missing
A dose.
a
Yeah.
dose or two doses. Like, I mean, I think you could probably go a week-ish, maybe more, but like don't worry about if you missed a few doses. It's okay. You can go
Yep.
back to where you were. If you missed 2 or 3 weeks, you might want to taper back up,
Sure.
starting lower. So yeah, I think that's an important thing. But yeah, I mean, it's really a pretty darn safe medication.
Yep. I would agree. How long do you keep patients on this? So I know listeners are going to say, well, how long do people take this for?
Wow. Well, I have some patients who have been on it for years,
So potentially forever.
potentially forever. Yeah, and I think it's one of those things like sometimes we can reset things in our body.
Mhm.
Like our bodies want to be well. So if we feed it, care for it, water it, move it, all of those things,
Mhm.
our bodies want to be well. So there is a potential that down the road at some point you could try tapering off of it. And maybe you've reset things and now you don't have the leaky gut that was leading to the autoimmune things and the immune system activation. So people can always try going back off of it. And my hope for people is like if we're doing our job together and trying to find the root of things, you don't have to be on a medicine forever. Like my goal isn't to have anybody, you know, I used to say take anything forever, but you're probably going to need vitamin D, let's just be honest. And
Right.
there's some nutrients that we need that we just don't get, but yeah, you could be on this long term and a lot of times, I mean, it's your choice too. Sometimes people will try to go off it and be like, you know
Yeah.
what, I actually feel so much better on that like,
It's
and
worth
I,
taking. Yeah.
for sure. And I think from a cost standpoint, people worry about cost with this. And in one of either in LDN book 2 or 3, somebody had gone to a low income clinic and they were worried about not being able to utilize this medication. And of course, somebody gave them a grant, but really, like most of my patients, I think it's probably 65-ish dollars for 90 days.
Yeah. Less than a buck a
And
day for sure. Yep.
yeah, and that's shipping it to Alaska. So
Hmm.
I don't know,
Hmm.
maybe it's cheaper if you're in the lower 48.
Sure. I don't hear people say that a lot in the lower 48. What about any further resources for someone who wants to consider low-dose naltrexone? So obviously we've mentioned the book. Any other resources you're aware of?
Yeah. Super great resource is ldnscience.org
Okay.
online. Really, really great resource uh, that has like it talks about what does it do? It will go through everything that we have talked about. What is it? What does it do? How does it work? What conditions does it work for? So I would say it's ldnresearchtrust.org. It's a really good website. The books, I looked up somewhere and I wrote it down there right now in PubMed, putting in LDN, there were 800 and I don't remember,
A
54.
lot. Yeah.
So
Wow. Yeah.
there's a lot of, so, so hopefully if you if you're curious about this and you do a little bit of research, which I would encourage everybody to do, is do some research on their own. But if you go to your provider then to ask about it, I mean, if you get shut down entirely, like to me, that's a ding, ding, ding. Think
Find
about
a new
seeing,
provider. Yeah. Yeah.
find somebody different.
Yep.
But it's not, it's pretty easy to find information about now.
Yep.
But, it's just variable. Like most of the rheumatologists that I work with don't use it. And a lot of times, like, I get it, but like in conventional medicine, a lot of times we're like, well, there's not enough data. And I'm like, well,
What
and
about for those patients who still have pain and can't tolerate the drugs? Can we think outside the box and just try something different? It's worth a shot. It's worth trying it
right,
in my, yeah. But
right. Yeah, and that'd be another question sometimes. It's not unreasonable, even if people are on disease modifying drugs for autoimmune conditions. So if you're on something for Crohn's or your
yep.
arthritis, it doesn't mean you can't utilize this.
Mhm.
It's not going to interact. I mean, the thing it's going to interact with is a narcotic.
Right.
That's what it's going to
Right.
interact with.
And I
So,
I have combined this with other drugs. I've just talked to their specialist to say, hey, can we
right,
just add this? And usually they say, sure, I guess. I don't know much about it, but we can try it. So,
absolutely. And I do the same thing. And that's the biggest thing, is just to try to have that communication. And
mhm.
hopefully with practitioners like us doing this, then some of the other practitioners are like, wow, those people tend to do really well. I wonder.
Maybe it is worth looking into. And yeah.
Yeah, exactly.
I want to go back to when we were just talking about some patients choosing to take this forever, because it's helpful, right? On the flip side, if, like you're saying, if we're able to dig deeper and get to the root cause of what is flaring up the immune system by changing the diet and, optimizing the hormones and eliminating toxicities and whatnot, then is there potential for patients who did use this in the short term as a tool, right, to get off of it? Yes. So just to be clear to the listener too, like, of course, right? Rather than just try going off of it, like we can certainly try to get to the root cause of what's triggering the immune system, lessen that fire, and then reduce or stop the LDN. So that's an
Right.
option too for patients, but just a good tool to talk about. So what other unique tools do you use in your practice? So obviously you're in Alaska, and I have not been. I would like to go. My aunt was
Okay.
a nurse midwife up there for years, and I never got to visit her, but she inspired me to kind of go down my career path. So, anything unique to your practice you want to share or kind of talk about? You already mentioned that obviously you have more of a functional medicine integrated family
Yeah.
practice, but anything else you want to share? Any other unique tools that you use?
Boy, unique tools. I mean, I think in the world that in my brain that I live in and the colleagues that I talk to, they're not so unique, but we're very wellness focused. So we we measure in bodies. So we do body
Yeah,
compositions on people. And
we
that's
do too. Yeah, yep.
right. In Alaska, that's not the most common thing. Um, I mean, I think some practices are, but not too many. We have a sauna in our office that we'll use. I do testing, cognitive assessment with CNS vital signs, which is a computerized
Yep, yep.
cognitive assessment tool. And that's really helpful because then if we make changes in diet, lifestyle, especially for somebody who might, as we age, like if you feel like your cognition is slipping, or people who have a family history of Alzheimer's or dementia, it's really neat to be able to utilize a tool, an objective measure, make changes, retest, and see like, oh wow, look at that, your processing speed has improved, and different things like that. So that's really neat. Uh, one other thing,
Go back to the in body. Sorry to cut you off, but explain,
yeah,
as I say, oh, we have that here, but like explain that to our listeners too.
yeah. So
Yeah.
an in-body is it's a scale. It's a fancy scale that gives you your body composition. So we know like how much muscle do we have, how much body fat, how much water. And
Mhm.
the in-body's pretty fun because it gives us like how much does your right arm weigh and your left arm and your each of your legs, and how much visceral fat, how much fat do we have
Mhm.
around our bellies.
Yep.
And to me, that's really important. Like you can you can imagine if we're trying to change our body composition or lose weight, people always be like, what should I weigh? And I'm like, that's a tough question to answer. I want to focus on body composition for people.
Mhm.
And so the other thing, that's often when people are trying to lose weight. We want to maintain muscle. With my folks who are older, our muscle is our brain health and it's our longevity. So we can utilize it to make sure over time you're not losing muscle mass. Because if you are losing muscle mass, you are declining.
Yep. Especially if you're on GLP-1s. I think that's
Yeah.
been super helpful for our patients. Well, I guess on the flip side, also sometimes patients are like, I haven't lost weight because I'm not losing numbers, but then we put them on the InBody and they have lost fat. So we can prove you
Right.
actually have lost, but also we can prove if they're losing muscle or gaining muscle too, right? Because
Right.
we don't want patients to just lose muscle mass. That would be horrible. Like you want to lose
Right.
fat and ultimately gain and maintain your muscle as you age. Like you said, it's that organ of longevity. So it is a cool tool. I'm
Yeah.
ashamed to say we had it here for a year before we even used it. Like it was just sitting in the box, and I was like, we got to get this thing installed and started using it. Then this past couple years, we really have. So yes, that's a great tool. I cut you off. I'll go back to the next thing you
No,
were going to say.
I mean, that's one thing that I just encourage our patients to use. And it's a great uh, tool for people to follow. Like they don't have to have an appointment with us. I mean, our patients can just call and be like, hey, I want to come in and do an in-body
Yeah,
or
yeah,
whatever. And they can do it. And I have a lot of people who do that to track, like,
yep,
and I encourage people, like, if you're going to make a change and you're changing something up at the gym or you're changing something in your diet, like, come in a month versus 6 months or
right,
like think about in conventional medicine we check your labs once a year. I can't, I mean if it changes for the better that's awesome, but I can't help you make changes with once yearly measurements of
right.
anything. Not effectively. So the one other thing that I was going to tell you, it's a tool but it's also kind of fun, and I don't have it sitting on my desk to show you. There are these little things called solutones. They are like little hockey pucks. They're dense and they do binaural beats. And so we will often, when our patients first come in and sit down, if they're waiting for me and the medical assistants helping them with something, we'll often utilize these solutones, and patients really love them because it's just grounding
Hmm. Yeah,
for
we don't have
people.
that.
Yeah, and they're inexpensive. There's probably been two people that are like, I don't like that sound. Like two people probably out of hundreds that have been like, I don't know. And especially if you have kids, man, they love those things.
Hmm. So they're holding these hockey pucks, or do they put them to their ear, or how do they?
Nope, they hold them. So you can hear them and you can feel the vibration. So you can
Hmm.
really feel it throughout your body. So they're very,
Hmm.
very, they're cheap. They're $150 or something.
Yeah, yeah, yeah,
They're
yeah.
relatively inexpensive, but they're very, very neat tool. And each cycle is 3 minutes. So you
Yeah.
just turn each one on and it's 3 minutes.
Fun,
So for
fun.
anybody listening that has like a racing mind or
Yeah,
has kids who are, I have a lot of uh, physical therapists, occupational therapists that work with developmentally challenged
yeah.
kids or uh, kids that have autism, those kind of things. Like they have found these things just to be amazing.
Hmm. Very cool. I'll have to look into that.
Yeah.
Anything else unique to Alaska? I mean, maybe I'm just like, you see like TV shows of, those who are just like living in Alaska and what do you call it? What do you call it when you're growing all your own food and
Oh,
maybe
right.
that's like living in the bush or something.
Yeah, I think so. I mean, we do,
Homesteading,
some.
that's the word I was thinking of, homesteading.
Yeah, that we do have some of those people. Some unique things are, we have some food security issues here. We have obviously we have salmon. Like
Hmm.
so if you eat fish, like that's great. Like I have a freezer full of fish.
Yeah,
Um, so that we have access to that, to moose, to caribou, so different like natural foods. We have a short but long growing season in the summer. We have long because of daylight hours,
sure.
but the season is short. And then beyond that, it's root cellar and we're relying on what gets shipped up and
Yeah.
really flown in. So
How long
I think food can be an issue here.
do you see more of, I don't even know how you would describe it, but of like SAD, seasonal affective disorder there? Do you
Yep.
see, yeah.
But
So do you,
I think not probably any more here than me being in northern Minnesota.
Minnesota? Okay. Yeah.
So any of the northern latitudes, probably pretty similar. Most, not all, most folks here are relatively hardy. If if you don't like being outside,
Don't move to Alaska.
don't move. No, like I've seen it time and time again. Like, I mean, there's a couple malls in Anchorage. Like, I I mean, I probably one of them I haven't been to, but probably twice in 21 years, and the other one I've been to like 10 times, 15 times. Like malls aren't a thing.
Yeah, yeah.
Uh, I mean, there are performing arts, there's different things like that here, but really it's about so much about being outside.
Fine, yeah. Nature, yeah. I'm in Iowa, and my brother always says he's lived in the Pacific Northwest and in Colorado and Columbia, and he's like, you have no nature there. There's just not a lot. We do have nature. It's just different. It's just a little different here, but
Yeah, you
Alaska's
have
on my
nature.
bucket list for sure.
Yeah, it's pretty fun in terms of population. We have, I think, in many respects, very similar population to everywhere else. This isn't going to be the listeners to this show. There's people who are very, very engaged with their healthcare. There's other people that are like, I just am here for a medication.
Hmm.
Like I just want somebody to fix something.
Right.
That I think that's the same everywhere.
Yep.
So yeah, I'm trying to think about other unique things here. I mean, people do crazy stuff, but I think people did crazy stuff in northern Minnesota and northern Wisconsin. I mean, there's some crazy people and there's some really tough people that you're like, you're kidding. I mean, there's still plenty of people up here that live in dry cabins.
Yeah.
And people are always asking, like, can you like drive to your house? Yes, I can drive to my house. Like the international airport's an hour away. So I can drive to my house. I can walk in town. I don't live in an igloo. Uh, I don't have an outhouse. But there are people within 5 miles of me that do have an
Hmm.
outhouse.
Yeah, yeah.
And I think you could find that in nooks and crannies in Iowa,
Sure, sure, probably.
for sure. So it's a fun place to live.
Well, tell me and our listeners where they can find you, like on social media. What's your website? It's best
Yeah.
place to find you.
So my website is in the process of being redone.
Sure.
So which will be great. It is nowhealthpalmer.com. My clinic is Now Health, and it's in Palmer, Alaska.
Okay.
And Now Health AK on Instagram, Now Health on Facebook.
Okay.
Yeah. And, I guess the one other place that you might find me is on this platform. You may be familiar with it, Stephanie. Know We Well.
No, but I saw that on your what you had submitted.
Yeah,
Yeah, I
so
don't know. Yeah.
Know We Well is an online platform that has different medical professions on there, anywhere from physicians to veterinarians to homeopaths to acupuncturists. The idea is that it's a collective of all kinds of different information. And I have a show that I have a monthly show in there called It's Empowering Patients to a Healthier Tomorrow. And so, yeah, it's super fun. So you might find me there and
Yeah, literally. No, we will. No, we
know
will.
we
Okay.
well. Yeah.
Okay. Cool.
And and otherwise offline, I'm just in Palmer, and otherwise I'm on my boat in Prince William Sound
Ooh.
or traveling.
Well, tell our listeners, last question here, your top longevity tip.
I would say my top longevity tip is take the time to figure out who you are, know who you are, and try to be true to that. I think we have so many pressures to be, and I would, speaking from experience as a medical profession, meeting needs for everybody, like all of us need to take the time though to meet our own needs. And for everybody out there that's a mom or a parent, we're so good at meeting everybody's needs, but let's take time to make sure we're meeting our needs and thinking about our goals and aspirations, because the more we can live in alignment with that, the better we are with everybody we interact with.
Nobody said that in over 200 episodes, so that was great. I like that. Well,
Yeah,
thank
I mean it's a constant work in progress, I
Oh
think, for
yeah. Oh yeah.
doing
Usually
that.
things I say I'm preaching to myself too, so
Right.
Well, thank you, Dr. Valerius, for coming on the show today and sharing your thoughts on the use of LDN. So many details. I'm glad we went into all that and sharing about your practice. You'd be a fun family doc to have. Maybe I'll come visit you someday. So thanks for coming on the show. This was wonderful.
Thank you so much. I would love it if you wanted to come visit. And thanks for the opportunity to talk about this exciting use of an old drug.